The question I get all the time is when to start insulin in a type 2 diabetic. We typically follow the ACE guidelines. The guidelines say any type 2 diabetic with A1C more than 9% should be considered for insulin. Now again, they say should be considered, it's not a must. The only time I would say it's a must if I see a type 2 diabetic in a catabolic state, no matter what the A1C is. A1C could be 9.5, 10, 12%, but they are losing weight at the same time without trying to lose weight. That means they are burning fat and muscle. Because if you lack insulin, that has a catabolic effect. So when they are losing weight in a phase of high A1C, then we have to start insulin right away. If they are not in a catabolic state, it depends on every patient. It depends on how many drugs they're on already. It depends how high the A1C is. It depends if it's high fasting, high postprandial, both are high. And it depends if we can use maybe other medications before we start insulin. I'll give you a quick example. If you have a patient who's on metformin and SU, but they have impaired kidney function, that means we cannot use SGLT2 inhibitors. They have gastroparesis. We cannot use a GLP-1 receptor agonist. And their A1C is 8.8%. Then my best choice is to add a basal insulin. So it depends on every case. It's not a standard, and it's more based on each individual.
So when it comes to insulin therapy, there's a lot of preconceived notions from the patient perspective. And so many think that if I'm starting insulin, my condition has progressed to this point where it's uncontrolled and I need to go on insulin. And in some cases, it's not that. You want early, aggressive, tight control in someone that has an elevated blood sugar or elevated A1C greater than 9% or 10%, where it's actually indicated and recommended for a variety of reasons. But again, from the patient's standpoint, it might signal disease progression. Other perceived barriers are it's going to cause weight gain, it's going to cause low blood sugars. These are the things that they've heard with insulin. And then the other one is regarding complications of it. So in a patient that might be on insulin, they could have heard from their neighbor or a family member where insulin was started, initiated, and then subsequent complications occurred. And it wasn't because of the insulin, it's because the disease was uncontrolled for such a long time that these complications set in. But again, they can't discern if that was the insulin or was it disease progression. And so because of that, patients will associate certain complications with insulin when actually it's to prevent those complications from happening. Those are the ones that I probably see most often.
So when we decide to start insulin in patients, after convincing patients that that's based on normal physiology, we all secrete insulin. And at some point when you have type 2 diabetes for a long time, your beta cells will completely burn out. So it's time to start insulin. And when you start insulin, it always works. As long as you pick the right insulin combination, could be basal mealtime, and you pick the right dose, and you titrate the insulin correctly in patients. Now, there are certain patients, typically up to 5% of them, who may be severely insulin resistant, which is defined as needing more than 200 units of insulin per day. That's when we can go to the more concentrated insulins, like U500, which will work in these patients. But even in those who need less than 200 units of insulin per day, we can still use other concentrated insulins, U200, U300, because one frustrating thing with most of these patients is the number of injections they have to do on a daily basis.